for joining. And for those here, also welcome to Grand Rounds. I'm Mari Yamamoto. I'm on the Grand Rounds Planning Committee. And again, really excited to have you all here and have our speaker. So I'll give a brief intro. We have Dr. Eric Chow here. He is the Chief of Communicable Disease Epidemiology and Immunization for Public Health, Seattle and King County, and is an assistant professor in the Department of Medicine and Department of Epidemiology at the University of Washington. He is board certified in internal medicine, pediatrics, and adult infectious diseases, and trained as a medical epidemiologist through the CDC's Epidemic Intelligence Service program. While at the CDC, he worked with the influenza division and led several COVID-19 investigations during the early days of the pandemic. He supported Public Health Seattle and King County's investigation of the long-term care facility COVID-19 outbreak and helped characterize the initial cases of multi-system inflammatory syndrome in children in the US in 2020. He has authored over 50 peer-reviewed publications, and his research interests are focused in community respiratory virus epidemiology, extrapulmonary manifestations of respiratory viruses, and emerging infectious diseases. So thank you so much for being here. We're really excited to hear what you have to share with us.
Thank you so much for the introduction, and thank you all for being here. It's a real privilege, and thank you so much for the invitation to be a part of your Grand Round series. Today we're going to be talking about the lessons learned from the COVID-19 pandemic. And I put together this presentation largely in response to a lot of inquiries that I've received recently. Why is it that public health continues to advocate and recommend layered approaches towards COVID-19? And why is it that COVID-19 continues to be at the core of our public health messaging? And it really reminded me, how far we've come in terms of our attitudes and behaviors towards COVID-19. And despite the fact that COVID-19 continues to circulate and cause morbidity and mortality, we've somewhat normalized some of this health outcomes associated with the disease. And when in reality, COVID-19, again, continues to circulate in our communities, we're still learning from COVID. We still realize that COVID has this ability to churn out these new variants that are likely driving a lot of these waves that we're seeing throughout the year, including during times when people least expect it, like the summer wave that we're seeing when people are trying to enjoy their vacations. And yet all we hear are about new infections. And we're just beginning to learn more about the long-term effects of COVID through long COVID. So in reality, what my argument is that we actually should be integrating a lot of these lessons learned into our routine activities and not to put COVID-19 behind us, because COVID-19 now circulates with other respiratory illnesses. And these lessons learned have important implications towards mitigating the health risks of other respiratory illnesses as well. So just a couple of disclosures. I received travel funding from Infectious Disease Society of America and also the Northwest Healthcare Response Network for attending infectious disease conferences. But we're going to be covering a lot of ground today. We're going to be talking about the pandemic milestones that I think are really, really important, especially the ones that continue to guide the principles behind our layered approaches that we're recommending today, and how this is going to continue to protect against COVID-19, the health effects of COVID-19 and other respiratory illnesses. We're also going to talk about some of the things that SARS-CoV-2 as a respiratory viral infection has taught us about not just the pulmonary implications of disease, but also the extrapulmonary and the systemic effects, including some of those which I know all of you know very well of, the long-term impacts of long COVID, which again, we're just beginning to learn about those mechanistic underpinnings that drive this disease process. And also to review over some of those things that were laid bare by the effects of the COVID-19 pandemic, the exacerbation of health disparities that continue to exist in our communities, and what it truly means to call COVID-19 an endemic disease, one in which we're starting to normalize and call a certain amount of disease baseline. What does that mean for those communities that continue to experience health disparities? Because we actually really haven't addressed some of the the main reasons why people experience inequities in healthcare resource access. And then taking all of these points together and bringing it back to those main core layered approaches that we continue to advocate for, and how all of you could help us continue to message the importance of these activities. So I'm going to start off by bringing us all back to December 2019. I think each one of us has their own personal story of how we first became acquainted with COVID-19. And when you look at the data and you actually think back to the earliest cases, the data seems to point back to most of the cases starting to emerge at the beginning of December. But it wasn't really until the end of December when news headlines started picking up on this cluster of pneumonia of unknown etiology because more and more patients were starting to get admitted to the hospitals locally. And for folks in China, this bore remarkable resemblance to something they had just experienced about 20 years earlier. Especially when more of these patients had epidemiologic links back to a seafood wet market that was local to that area. And because of the growing number of reported cases, China went ahead and made a report to the WHO country office soon thereafter. And again, this is where we started hearing about it in headlines here in the United States. And by January 1st, the seafood wholesale market ended up closing because of all these epidemiologic linkages, even though an infectious disease agent wasn't identified at the time. And CDC started making preparations. At the center level, the National Center for Immunization and Respiratory Diseases started their center level response, getting prepared for if this cluster of pneumonia started expanding beyond China. And sure enough, in the next few days and weeks, it definitely did. On the same day, the first genetic sequence of a virus identified in some of the specimens was sent over to the China CDC, thinking that this could possibly be the infectious etiologic agent. And it wasn't until 2 days later that the government was able to confirm that, in fact, this novel coronavirus was actually the cause of this pneumonia outbreak. Now, again, a lot of information was still trying to be gathered. There's very little information about what the clinical course was, what the mortality rate was. But up until this point, we didn't really know to what degree it would impact people in terms of their health outcomes. But on January 9th, China reported the first death due to COVID-19. So this was a realization that now we have an infectious disease agent that was responsible for this growing number of previously a pneumonia of unknown etiology. And now has this mortality risk, but to what degree we didn't know at the time. And at the same time, WHO finally called the virus the 2019 novel coronavirus, partially to combat this growing use of this term Wuhan virus that was creating a lot of stigma. And they bought a little bit of time until they formalized the terms, which I'll describe in just a bit. On that same day, the first genomic sequence was uploaded publicly to GenBank and then shared with research scientists across the world to start developing diagnostic tools and also medical countermeasures to hopefully curb the spread of this infection. To no one's surprise, the first case of COVID-19 was then discovered outside of China in Thailand on January 13th. And I think for me, certainly this was a turning point, realizing once again that this wasn't going to be contained to one country's borders. And to add kind of fuel to this urgency, China confirmed that, that initial idea that most cases or all cases were somehow linked back to the seafood market was actually not panning out anymore. Unfortunately, we're starting to see substantial human-to-human spread. And actually, I think that this is best illustrated in this New England Journal article showing this epigraph of some of the early cases of Wuhan, the novel coronavirus in Wuhan. And so let me orient you to this graph. So on the x-axis, of course, we have the days from December through January 2020. On the y-axis, we have the number of cases. The dark orange bars are the number of, or the cases that have epi links back to the market. And then the peach colored bars are the ones that have absolutely no linkage back to the market. And I think the pivotal point here is January 1st. You can see to the left of January 1st, you can see that vast majority of cases had some sort of epidemiologic link, and it grew rapidly thereafter, showing substantial human-to-human spread and, of course, likely contributing to the community spread of this virus. So this is around the same time that US got its first experience with novel coronavirus. So on January 20, 2020, the first case of COVID-19 was diagnosed and identified here in the United States. This is a person who actually was identified a resident of a county just north of us. And they identified themselves to healthcare because they had heard about these health alerts of this growing pneumonia in people who had recently traveled to Wuhan. And he had respiratory illnesses. And it's like, hey, you know what? Maybe I have this virus that people are talking about. And this case also happens to be the first person to have been treated with remdesivir, at the time an investigational drug, not known to what degree it would have effectiveness against severe disease. Fortunately, this person did survive and recover. On January 30th, Chicago declared the first evidence of person-to-person spread here in the United States. Again, when you read about this case in retrospect, of course, to no one's surprise, one person in this family unit had traveled to Wuhan, came back with respiratory illness, and then another household member subsequently got ill. But I think the significant thing about this investigation at the time was that through all their exposure investigations, no one else seemingly got ill from this one individual. So it's thought that the infection was actually contained to these two people. On January 31st, the WHO took its first significant step in declaring COVID-19 a public health emergency of international concern. And the US Department of Health and Human Services followed suit, declaring a public health emergency, which actually continued until May of 2023. On February 11th is when we started getting the formal terms, the terms that we continue to use today. So WHO called the disease the coronavirus disease 2019 or COVID-19, and the international body that governs naming and nomenclature for viruses called it the severe acute respiratory virus coronavirus 2. The severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2, the virus that causes COVID-19. I don't know how many of you had a chance to listen to a live telebriefing given by Dr. Nancy Messonnier, but I would actually encourage you to even go back and listen to it. So Dr. Nancy Messonnier was the Center Director for the National Center for Immunization and Respiratory Diseases at CDC. And on February 25th, she gave a very unambiguous kind of press briefing indicating that COVID-19 was very much on our doorstep. She made several statements that seemed to suggest that she has some sort of crystal ball to tell you what the events were going to happen just a couple of days after. But she says that COVID-19 is no longer an issue or no longer a question of if, but when. It was actually going to cause substantial serious illness here in the United States. There was going to be community spread, and actually it was going to impact and substantially turnover and impact our daily activities and our lives. And almost as if, again, like she was able to predict this, 2 days later, Dr. Helen Chu and colleagues through the Seattle Flu Study, colleagues right here at the University of Washington, detected the first case of COVID-19 that suggested community spread. This is a person who had absolutely no exposure risk factors to travel and no other exposure risk factors to people that they knew had respiratory symptoms at the time, which suggested that there were already probably several generations of infection that was circulating in our communities. And it proved a very important point about their surveillance program because it was meant to detect viruses with pandemic potential earlier on so that the government could take action. I want to highlight some of the work that they did because it's pretty remarkable. Because in 2019, Helen Chu and colleagues kind of came together and said, our existing surveillance systems are inadequate. We need something in the community where people could test and we could get those specimens. And that's exactly what they did. And it's detailed. And if you have time, I would encourage you to read some of these kind of now historical documents. This one published in the New England Journal of Medicine talking about the detection of that first case. And also Dr. Trevor Bedford's and colleagues is their story of using genomic sequencing to detail out the cryptic transmission of COVID-19 early on in the pandemic here in Washington. It feels very ominous and reading it in retrospect. Thereafter, the series of events happened in rapid succession. On February 29th, CDC in Washington State announced the first death due to COVID-19 here in the United States. Again, right here in Washington, this time shedding the limelight here in King County because this was a resident of King County. What I think probably most people didn't realize is that Public Health Seattle King was already receiving calls concerning for a respiratory illness of unknown etiology. Feels very familiar with given certain conversations recently. But just to bring you back to kind of the mentality at the time, most people, the testing screening criteria all required people to have some sort of travel exposure or exposure to someone with known COVID-19. These are long-term care facility residents. They didn't travel recently. The healthcare workers didn't travel. So, I mean, is this really, like, should we really be considering COVID-19 our differential? So that was a big question. And just, it wasn't until February 27th or 28th when CDC finally expanded their testing criteria to include people with respiratory illness of unknown etiology. If it's not flu, maybe we should be considering COVID-19. And so there was one of these residents that then got admitted to a local hospital. And again, astute clinicians and also really brave public health folks made the decision to go ahead and test this individual. And sure enough, this person had SARS-CoV-2 infection, which implied that that respiratory illness outbreak back at the facility was actually due to COVID-19. This actually marked the beginning of the COVID-19 pandemic for the United States. This is the first this is the first outbreak due to COVID-19 happening in this long-term care facility in King County. And in an effort to quickly, hopefully, contain this and further investigate the outbreak, how did it happen? Where did it come from? How far was it spreading? And also to answer some basic epidemiologic questions which we didn't know at the time. How was it spreading from person to person? What were the transmission dynamics? This was an opportunity to maybe study it further, to form the basis in our knowledge that we actually continue to use in our guidance today. So Public Health Seattle-King County invited CDC to come and help investigate, initially sending 10 people, but then 50 people came thereafter to really contribute to the investigation, which I know many of you probably recall what was happening and the chaos of everything that was happening at this point from the front lines of taking care of patients. But this is what's happening here in the public health realm. And also just to illustrate another point that is well known to us today, and a principle that I try to carry over to explaining why it's so important for us to kind of formulate kind of teamwork and interconnected processes to make sure that if to highlight one point, that if one facility is experiencing an outbreak, all our facilities are probably going to be at risk. And so to illustrate the interconnectedness of our facilities at the time, you can see facility A had a lot of shared healthcare workers, a lot of patients transfer at the time. So one facility experiencing COVID-19 was likely going to put all these other facilities at risk. So we all have a role to play in kind of mitigating those outbreaks. And again, it has practical implications for some of the other public health work that we do with facilities today. So a lot of our work went into really trying to form the framework and the basis for a lot of the guidance that we continue to use today. What is happening with COVID-19 that makes it special, and why is it spreading so quickly? Well, one of the questions that we tried to ask early on, can we use symptom screening to identify people? And this is and so we tried to explore this by interviewing all the healthcare personnel, the first 50 that were identified with having COVID-19 here in King County. And we asked them, what symptoms did you have when you first started feeling ill? Because at the time, people assumed that, oh, fever marked the beginning of your illness course. But in reality, certainly now that we know, a lot of people actually don't even have fever throughout their illness course. There are other symptoms that people have that indicate that they have COVID-19. That if we're going to use symptom screening criteria, we're going to have to have a broad range of symptoms to be able to capture everything. And even then, it might not be feasible to stop someone from transmitting it before they, spread it to other people. And what further complicated this was this study, or the findings of this study, which was done at a skilled nursing facility that actually recently experienced an outbreak at the same time we were doing this investigation. And they went ahead and swabbed a bunch of people and then followed them over their illness course. And what they found is that actually those people, before they had symptoms, those people who were pre-symptomatic or even asymptomatic actually had substantial viral loads. Actually, when they cultured some of the specimens, they actually found live virus, which implicated that actually people even without symptoms could be spreading this infection. So symptom screening alone probably wasn't going to be sufficient if we were going to try to contain this virus. Needless to say, a lot of this information was kind of pointing to a very urgent issue where there's so much more that we need to learn about COVID-19. It was going to be very difficult to contain. Over 100 countries were now experiencing COVID-19 outbreaks. So finally, WHO declared COVID-19 a pandemic on March 11th. So just to bring us back to that time, the early days, a lot of us were probably thinking about, in terms of pandemic preparedness, we were thinking a lot about influenza, right? And influenza has a lot of things to kind of teach us about kind of how to bring people together and like what community mitigations could be helpful to kind of slow the spread of virus in the community. But there were other kind of like factors around coronavirus that kind of made it special. And we probably should have seen some of the foreshadowing given some of our experience over the last 3 decades. So back in 2003, of course, that we had SARS-CoV-1, which indicated, wow, yes, a novel coronavirus, a zoonotic coronavirus could have substantial human health impacts. And of course, then our experience with MERS-CoV in 2012, and then both of these experiences probably told us that SARS-CoV-2 was just around the corner. So, kind of going back to that early period, one of the most important things that the Chinese scientists were able to do early on was actually upload that genomic sequence early to GenBank to share that publicly, even before some of these countries were experiencing COVID-19, because this had implications for development of diagnostic tests and also, as I mentioned earlier, medical countermeasures. So from the sequence, we were able to say early on, well, this is a single-stranded positive sense RNA virus that actually had some important viral structures that helped us understand how it was causing disease in people, and also helped us identify possible vaccine candidates to develop later on during the pandemic, and also some antiviral candidates that we could possibly use to mitigate the risk of severe disease. And so just to review some of those basic principles that we had learned earlier on. So there are main components to the SARS-CoV-2 virus that are required for it to be able to enter a host cell and then replicate. One of which is the spike protein, which most of you are already aware of because this is the target of our vaccines that we have today. We also have the membrane protein, the envelope protein, the nucleoprotein, and a number of other enzymes that are essential for the virus to be able to replicate. So as you recall, the spike protein is really crucial in a lock and key method. It actually attaches to the human ACE2 receptor, which is actually found throughout the body, but actually is one of those prime receptors on a respiratory epithelia that allows the SARS-CoV-2 virus to be a respiratory virus. It unlocks the door into the host cell and then hijacks the host cell machinery, and then allows it to replicate. And if you were able to find an immunization or antiviral that interrupted any part of that process, you could potentially slow the spread of disease. And that, I think, has come true. Obviously, the vaccine, which targets the spike protein, and also some of the antivirals that we use today. So most of you are probably familiar with Paxlovid. The active ingredient is nirmatrelvir, which targets the virus's protease. And obviously remdesivir, which targets the RNA polymerase. And also molnupiravir, which is actually very interesting. It doesn't actually target any one enzyme. It actually induces the virus to produce more mutations. With more mutations, it becomes more deleterious to its ability to replicate, and then halts the virus from progressing in that manner. So we were asking a lot of questions about, again, what symptoms should we be screening for? And again, I think a lot of our thoughts were kind of biased towards, okay, respiratory virus causes respiratory symptoms, right? But I think SARS-CoV-2 kind of upended that a little bit and really made us question if we really understood what a respiratory virus was. So not to insult anyone's intelligence, we're going to review this a little bit. So of course, what makes a respiratory virus is that a respiratory virus transmits from person to person via the respiratory route. Most people probably associate respiratory illnesses, and for the most part, most respiratory viruses do have respiratory symptoms. But also remember that measles, varicella, rubella are also respiratory viruses, but have systemic symptoms. And just as a side note, we also have other viruses that can cause respiratory illnesses as well, including herpes simplex virus in neonates and adenovirus in neonates, and also adenovirus spreading from person to person via the fecal-oral route in some cases. All good examples that actually there's a whole spectrum of diseases that viruses can cause. And respiratory viruses don't all fit neatly into just one box. So again, going back to this idea that most of us had this idea that we're looking for respiratory symptoms, but early on, we're already discovering that just looking at these respiratory symptoms wasn't capturing the experiences of everyone's clinical course. So maybe we should be asking, what symptoms should we be looking for? We should actually take a step back and actually have people tell us what types of symptoms are actually associated with COVID-19. And when we started approaching things that way, I think we started to learn more. Again, of course, some of these are really common: runny nose, congestion, cough, shortness of breath, fever. We knew those. But also headache. Headache was a pretty prominent feature, and it continues to be a prominent symptom that people experience today. Sore throat, GI symptoms, certainly was something that people talked about early on. And this beauty, how many people remember COVID toes? We talked about this so much. Fortunately, I don't think it's carried over it's not a common symptom anymore, but we've talked about this to death. What were the implications of COVID toes on the clinical course of people's clinical course? And in fact, this is chilblains. This is inflammation of the smart arterioles of the skin, affecting mostly the digits. We saw all sorts of rashes. I probably saw more dermatologists come into the hospital than I have during the entire time, during my entire medical career. And of course, this famous symptom that people are still associated with COVID-19 today, which is alterations to sense of taste and smell. And I want to spend a little time because the history behind this is actually kind of interesting that most people may not know. So again, a lot of people, like, oh, well, of course you're not able to smell. You have severe congestion. But actually something else was happening. More and more people were starting to describe at the population level huge trend changes in what people were describing as alterations in smell and taste. And this Italian group actually characterized this across their entire Italian population and realizing that in many cases of people getting diagnosed with COVID-19, this may have been the first and only symptom that people had. And this was an important kind of like additional symptom that we should be looking for in people who have COVID-19. And so this had huge implications because, as you're aware, the olfactory bulb is actually mostly neurons, right? And so the fact that you could have potentially a neurotropic virus had huge implications on the potential clinical ramifications of a person getting infected, right? What happens if that virus then gets into the CNS? It's going to be so difficult to treat, and not to mention the morbidity that would come from it if someone survived their infection. But it took us a while to kind of get here, but we soon realized it was actually not a direct invasion of the olfactory sensory nerves. It was actually invasion of the support cells, many of those that are respiratory epithelium, a lot of them that had ACE2 receptors. And this was the favorite target of SARS-CoV-2. It was specifically the sustentacular cells that were being targeted. And without those, when those died, the olfactory sensory nerves died as well. And so that is why people had anosmia and changes in sense of taste or smell at the time. And it took a while, of course, because neurons take a while to grow back. Also, the sustentacular cells also had to grow back. So someone had to clear the infection and then subsequently have all those parts of the olfactory bulb return. So this prompted a lot of people to think, well, if this is the first and only symptom that some people might have, could this be used epidemiologically to predict when a COVID wave would be coming about? And so as a proof of concept, this French group actually took a look at the French population and said, well, actually, in fact, yes, based on the data early on during the pandemic, you could actually graph trends and changes and alterations of sense of taste or smell and be able to predict subsequent ways. Unfortunately, this really hasn't panned out for the rest of the pandemic, but kind of interesting. And then this kind of interesting story, I don't know how many of you have read this, but there was actually some people noticing that there was an increase in the number of negative reviews on Amazon towards Yankee Candle saying, your candles don't smell. And this actually seemed to predict when a COVID wave started coming through. Anyways, kind of interesting read. I don't know how true it could actually be, but interesting nonetheless, something that also came out of the pandemic. So here we are. We were finishing up our investigation here in King County, just realizing all the things that we still needed to learn about COVID-19. So we all went back to CDC at the time. And CDC kind of placed us in positions to be able to start collating all the information that was being put out. Just remember all the information that was getting published, anecdotal reports, all this information we had to kind of sift through to kind of to quickly synthesize and put it on the CDC website to address people's most common questions. Again, something that was evolving and required us to constantly update over time. So one of the things, because of my pediatric background, they asked me to track all the pediatric kind of reports and the severe cases. And of course, we knew that severe disease was possible in children, but maybe not to the degree that it was in adults, until we started hearing cases about Kawasaki-like illness that was appearing. And we got media inquiries, all these inquiries about like what's going on. And, again, we didn't see that happening in the United States yet. It was actually based off of some of the initial reports from the United Kingdom, who actually saw an increase in the number of children who were being admitted with Kawasaki-like illness and also toxic shock-like features. And what was going on? Is this related to COVID-19? What they showed was a graph similar to the one that we had subsequently published. So in the red, you can see the number of increase in children admitted with Kawasaki-like disease. And then in the blue, you can see the epi curve for the number of pediatric cases of COVID-19. You can see everything shifted by 4 to 6 weeks. So is there an association or is there a complete separate process that was going on? That was the question that we were tasked to answer. And so fortunately, we had colleagues over in New York State that actually started to see some of these cases come through, and they actually made all Kawasaki's disease, all toxic shock, all myocarditis mandatory reporting so that we could further understand this. And so this provided us an opportunity to be able to describe what this condition was and provide enough information to formalize the first case definition and ultimately call it the multisystem inflammatory syndrome in children. And in fact, there was this association. And kind of an interesting observation earlier on that some of the clinical presentations actually varied by age group, that younger children had more dermatologic and mucocutaneous presentations as opposed to the older children who had more neurologic and gastrointestinal features. Very interesting. And you may have heard cases of this, like children come in with such severe abdominal pain, they're actually taken to the OR to get their appendix taken out, and their appendix is perfectly fine. And that was the case, that was the situation that we heard over and over again associated with multisystem inflammatory syndrome. So again, so it's kind of an interesting time. We had to give a new name so that people would be able to study this appropriately. But we knew that yes, we were identifying in children, but it was likely going to also happening in adults. We just haven't identified it yet. So some names that came about were probably not the most appropriate. For example, the first name that people threw out there was pediatric multisystem inflammatory syndrome, or PMIS. So PMIS is probably not the most appropriate name for a childhood syndrome. So we decided to move in the direction of, again, something that could also be inclusive of adults. So we went with multisystem inflammatory syndrome that then could be in children and adults. And sure enough, a few weeks to months later, adult cases previously categorized as severe acute COVID-19 actually had more features in that was similar to multisystem inflammatory syndrome in children. And so there's a number of case series that have now been published on this topic. So one of the big questions that certainly we were asking at the time was like, okay, well, now that we've identified this disease, what is the underlying pathophysiologic mechanism? Because if this is antibody mediated, this has huge implications on our vaccine candidates. We don't want to create a vaccine that induces multisystem inflammatory syndrome. So we were thinking, hypothesizing, what were the possible kind of pathways for this? Because again, there's not very much research and not much known about it at the time. Immune complex deposition, could this be antibody potentiated viral entry into cells like we see with dengue? Or is this direct damage from the antibodies? It actually took some time for us to maybe come up with a viable theory. It was actually molecular mimicry is described in this paper just published in August that suggested that it's actually an autoantibody that's shared across different children who have MIS-C that then targets one of SNX8 protein, which is part of the antiviral pathway in response to a previous infection, that then leads to MIS-C pathogenesis. And the same autoantibody, if you put it into a container with SARS-CoV-2, it actually targets the nucleocapsid protein. And if you actually overlay the sequences between the two proteins, they have a remarkable sequence similarities. So again, there's still things that we're still learning even at this point in the pandemic. Very, absolutely fascinating in my mind. Okay, so here we are. We now have a better understanding of some of the symptoms and kind of clinical complications associated with COVID-19. We now know that this is going to be a beast to try to contain because a lot of people with who are asymptomatic or potentially could spread it. Even people who are just talking to one another could be spreading it. So we really need to make sure that our guidance took all of that into consideration. And then this is actually an interesting statistic that I would like to make sure that you're all aware of, that actually it was later in the pandemic with enough data that we were able to model and show that at least 50% of new SARS-CoV-2 infections are actually because of asymptomatic spread. So this is a statistic we continue to cite today as the reasons why layered approaches are really important, especially in indoor crowded spaces and such. So remember at the time, again, there's a lot of things going on. Our hospitals, healthcare systems were essentially falling apart with all the people coming in because of severe disease. We needed more time to be able to build relief for the hospitals, but also more time to be able to develop medical countermeasures. So community-wide mitigation efforts took place at that time, including community lockdowns, and this very important tool that still has a really relevant place in our activities today, which is masking. And remember, it took a while to explain to people it's not just the person who's afraid of getting infected, it's everyone should be participating. This will reduce the concentration and spread of the virus at the time. Of course, all this messaging was also difficult because it's coming at a time with supply chain issues. We're trying to prioritize PPE for frontline workers. So what are we going to tell the general population? That actually our most effective PPE is actually only for those people, but what should you use? So A large group effort through a lot of the federal agencies tried to highlight the importance of using everyday items to create face coverings. And you can see, I don't know how many of you saw this video by Dr. Jerome Adams, the U.S. Surgeon General at the time, just advocating ways that, showing ways in which you can turn everyday items into face coverings. Again, with this idea that the only interactions and possible exposures should be few, and in those situations, these types of face coverings, despite now knowing that it was going to be an aerosolized airborne virus, this could help further mitigate spread in the few instances that people are going out for essential activities. But one thing that's, I think, particularly remarkable about the non-pharmaceutical interventions, particularly the layered approaches, was that it had a huge dramatic effect, not just on SARS-CoV-2, but other respiratory viruses. So this is a graph from the Seattle flu study, where each different color is actually a different virus. And you can see probably what date? April 2020, when all the community mitigation measures came into play. And it had a huge, profound effect on all the community circulation of respiratory viruses. And that played out particularly in influenza. So this is a graph from WHO data of the number of influenza cases reported from around the world. And you can see, again, around April, you had a dramatic decrease in the circulation of influenza. And this has continued through until 2022. It was so effective that actually we all hypothesized eliminated one of the seasonal influenza viruses, influenza B Yamagata, to the point that we're so confident at this point that actually we're changing the quadrivalent vaccine back to a trivalent vaccine this year. So again, a remarkable outcome of some of the community mitigation efforts at the beginning of the pandemic. So, all right, talked a lot about the viruses, talked about some of the clinical illness complications. I want to talk a little bit about some of the other health effects that King County helped the rest of the world kind of better appreciate. I think here in King County, we're very intentional about laying out that we experienced health disparities before the pandemic. The effects of the COVID-19 pandemic were likely to exacerbate these health disparities. We need to capture this data early on to be able to highlight this. And unfortunately, the data actually pointed to health disparities as of May 1st, 2020. And again, remember that not many people had access to testing, so this is likely an undercount of the true cases that were happening at the time. But you can see already here in orange, Black, Hispanic, Native Hawaiian, Pacific Islander had substantial greater case counts at the time than their white counterparts. And this was something that would play out for the rest of the pandemic, again, because there are systems of oppression, systemic racism, historic inequities to healthcare resource access that continue to play out. And unless we address those root causes, these inequities would continue. And of course, subsequently, a lot of publication. It wasn't just here in King County, but these health disparities were seen across the country. So to hold ourselves accountable, again, this is work that we kind of put front and center in all our public health work, but to highlight the importance of addressing racism as a public health crisis, so the King County declared racism as a public health crisis on June 11th, earlier on during the pandemic. And this became the centerpiece of kind of all the work that we did. Are we meeting the community's needs? And one of the strongest ways in which I think we did this that carries into the work that we do today is putting together the Community Navigator program. Again, with this idea that one size does not fit all when it comes to any type of intervention because there are unique needs of various communities, we had community leaders, public health advocates join our team to help us engage in a bidirectional exchange of information. At the time, remember how quickly information and guidance was changing, right? For clinicians, it was hard to keep up. Can you even imagine what it was like to keep up in the general community and making sure that it was in people's primary languages, et cetera, in ways that was accessible to them? And so we relied heavily upon the community navigators to help us disseminate that information. And most importantly, this provided a pathway for people to share concerns of theirs with us. What information, misinformation were they hearing? What disinformation were they hearing, which was unique to each individual community? Again, a process that we learned to integrate into our activities now, and we continue to carry this Community Navigator program forward. And it was because of these really strong partnerships that we were able to make a very difficult thing happen. We were able to achieve an 85% vaccination rate, completing primary series of the COVID-19 vaccine among eligible King County residents at the time. I think it's a remarkable feat for the amount of time that we had and how quickly we needed to do it. And we were able to do it across all different communities, which is awesome. And it was because of these partnerships, academic partnerships, the healthcare system partnerships, partnerships with faith-based organizations, and just a lot of people who are really passionate about safeguarding and trying to close the gap on healthcare disparities. So again, another kind of sobering reminder of kind of the effects of the COVID-19 pandemic, and something that we're likely to continue to see as we move forward until we again address some of those root causes of the systemic inequities to healthcare resource access. But this data was actually just recently published on our Public Health Insider blog, looking at the death rates by race ethnicity. This is all cause. This is not just COVID-19. And across all racial ethnic groups, there was actually a 7% increase in death during the 2020 to 2022 period compared to the right before the pandemic. But you can see actually American Indian Alaskan Natives and Native Hawaiian Pacific Islanders actually saw a 40% increase in death relative to the period pre-pandemic. And again, this points to a lot of harm that was happening in our communities. And unless we continue to elevate these data points, it will be lost in the conversation about what to do next in this next phase in the COVID-19 pandemic. All right, this graph is to illustrate that, again, at this point, we've been through many, many phases of the COVID-19 pandemic. Wild type, alpha, delta, and the many subvariants of Omicron, and it brought us up to more recent times. Now, you probably remember last year, there was a lot of conversation about what does it mean to end the US public health emergency around COVID-19 pandemic. And while I think a lot of the talking points was, well, this is an administrative move, this is a direction that we had to go in, we have many more medical countermeasures at our disposal that we can fight against and mitigate the severe disease associated with COVID-19, which was definitely true. We have more community immunity. But a lot of people took this as this is the end of the pandemic, which is problematic. So we put out a lot of messaging, including this Public Health Insider blog, to remind people that, in fact, the end of the public health emergency does not spell the end of the COVID-19 pandemic. We, in fact, have a lot of work to do, especially now that the COVID-19 vaccine was now becoming commercialized and people had to pay out of pocket. A lot of people didn't want to supply it. Even a lot of clinics and hospitals didn't want to give it. So everyone had to go to pharmacies. A lot of these things that just created more barriers, again, access to these things that we're saying that we now have access as tools to combat COVID-19. And it's problematic because I think a lot of people were also saying, oh, okay, it's the end of the COVID-19 pandemic. Maybe COVID is just a common cold now. But look, COVID-19 continues to circulate year round. I think going back to that point I made earlier, the only thing predictable about COVID is its unpredictability. It continues to churn out new variants and actually increases at times when people least expect having a respiratory illness. This is not flu and RSV, where there's seasonal peaks and then low circulation for the rest of the year. This is what people think COVID is, but in fact, COVID is very much not that right now. And it was also problematic in my mind that the federal government were also making moves to make it seem like it was a seasonal virus. So ACIP meeting last year at the beginning of September to finally approve the recommendations for the upcoming season, right when we were experiencing a wave of COVID-19. Now, I think they learned from that a little bit. They moved up the decision to June so that now we have vaccines a little bit available a little bit earlier, but still there's some problems. We should probably be moving this decision up and distributing vaccines a little bit earlier during the summertime, when now we're seeing over 3 summers, there's an increase in COVID-19 burden in our communities. So again, COVID-19 is not flu. Let's not try to fit it into a flu box, even though they have some overlapping respiratory symptom similarities. And it's also important to know, and this is a talking point I also use because a lot of people try to, again, compare it with flu. COVID-19 is still more deadly than the flu. And not to mention there's long COVID. Now, I know you have experts right here in your department who are leading the way to help us better understand long COVID. So I'm not going to talk in a lot of detail about long COVID, but just to quickly review, though, that up to 10% of people who have previously had COVID-19, even if it's asymptomatic or mild, could go on to develop long-term sequelae. It affects people of all ages, regardless of your underlying conditions. And actually, we're showing that vaccines have a really important role to help reduce your risk of subsequent development of long COVID. So again, one of the those important tools that we continue to highlight today. But again, an important question. While we talk a lot about hospitalization, healthcare disparities in terms of hospitalizations and death, but also now with long COVID in the mix, we should really be thinking about that. Because remember, when compared to white populations, Black and Hispanic populations have higher rates of SARS-CoV-2 infections, higher risk of hospitalization due to COVID-19, which puts them at greater risk for long COVID, which probably means that we have higher rates of long COVID if we were able to measure it. And some of this has come out in some of the literature published too. I highlight this one, highlighting that BIPOC individuals actually experience a greater health burden and also quality of life impacts than white populations when it comes to long COVID. And in those situations where people are trying to provide resources to support people with long COVID, in this one clinic, Black populations had lower utilization of outpatient rehabilitation services. So there are hurdles and inequities in accessing some of these important healthcare resources. But again, there are a lot of studies other than just this one, but a lot of studies that point to the reduced risk of staying up to date with recommended vaccinations. So this should be one of our talking points when we're talking to patients about the importance of staying up to date. In this study, it actually showed a risk reduction of about 50%. That's pretty good. That in itself should be selling the vaccine. So other changes that came about. So March 1st of this year, I think one of the things that were in a lot of the news headlines was our mitigation measures in the community, how CDC was now kind of bringing all the respiratory viruses together and calling it respiratory illness and no longer requiring testing as part of the reasons why you should stay at home. And a lot of people, I think, got a little enthusiastic about some of their responses to CDC. I have to admit that initially my gut reaction was just like, is this really the right way moving forward? So again, they're going by a symptom-based strategy, telling people that when you feel ill, it doesn't matter what your symptoms are. If you don't have another explanation for your symptoms, you should be staying at home and away from other people. Again, emphasizing that the issue that we even see here in healthcare, presenteeism, this desire to, or this impetus to feel like you need to work even when you're ill. Again, this addresses a point that I think CDC acknowledged. Most people don't care or don't even know the differences between the different respiratory viruses, whether it's SARS-CoV-2 or flu or any other respiratory virus, right? So they integrated this into the guidance, try to make it simple, especially now knowing that access to testing is not readily available for most communities. So what are the simple practical steps that people can take to now help reduce the risk of transmission in their communities? It's not going to capture every single infection out there or apply to every single person who maybe doesn't have any type of symptoms but still have an infection. But this will start to move that needle in that conversation about what we should be doing if we were to be ill. So I don't know how many of you follow Caitlin Gedolina, but she is an excellent public health communicator. If you don't already subscribe to your local epidemiologist, I just like to listen into some of the conversation. She takes complex public health ideas and talking points and helps to condense them back down to kind of plain language that I actually find helpful to me as a public health person. And she really tackled this question of what are the implications of this changing COVID-19 isolation guidance, and specifically to address the public health people's concerns that actually this will make people think of COVID-19 like any other respiratory virus. And actually, this is a huge step backwards. When in fact, she's like, actually, let's reconsider and let's take a look at the facts. This actually might be moving us forward. And also, she reminded us that, again, part of the mitigation measures that we're advocating for are masking. And at one point during our history, people pushed back on seatbelts, which now we feel like is normalized. So we have some ways to go to also normalize masking in our everyday activities. But she does question what is public health and challenges us all to think about that. Is it really talking about best practices and holding ourselves to this higher standard? Or is it really meeting people where they're at, recognizing that a lot of people's their behaviors and attitudes have changed towards COVID-19 and really trying to adapt and just slowly moving the needle a little bit in our everyday practices. And so again, she drew this really impactful figure. I really appreciate it. So I'm going to review over it a little bit. So this dark area, these are the asymptomatic, pre-symptomatic people. This change in guidance is not going to impact them, right? They don't know that they have the infection. The guidance is really about people with symptoms. So really the people that you're going to be changing the minds of are that slim, narrow margin of people who have symptoms and are trying to figure out what is the best approach to be able to reduce transmission. And that is the gain that we're trying to achieve here. And of course, there's those people who already knew they're probably going to test. They have the privilege and access and all these other kind of great things to help them be able to reduce risk of transmission. But you're trying to tackle, again, the people who are trying to do the right thing, but trying to distill through all the misinformation, disinformation out there, what is the best way forward? And CDC was really trying to move the needle there. So I'm coming up towards the end of my presentation. Oh, perfect. Thank you so much. But I want to end on this topic because this has come up so many different in many different ways, particularly the questions that I get about whether I qualify COVID-19 or the pandemic over. So I bring people's attention to this perspective article that was written recently by Joel Abi-Rashed in the New England Journal of Article. Of all the different resources that I provide you today, I really strongly encourage you to read this one because, I believe this is at the core of kind of everything I think about when we talk about recommendations coming from public health and what I think a lot of us as clinicians should be advocating for because of this statement that Dr. Abi-Rashed wrote in this article. So I'm going to read it to you because I think it's that important. So the declaration, the end of a pandemic, therefore marked a critical point when the value of the human life becomes a variable of actuarial significance. In other words, when the government determines that the social, economic, and political costs of saving a life exceed the benefits of doing so. It is neither epidemiology nor any political declaration that determines the end of a pandemic, but the normalization of morbidity or mortality and morbidity by means of a disease routinization and endemicization, what in the context of the COVID-19 pandemic has been called living with the virus. I want you to sit with that a little bit, but we're also short on time, so I'm going to keep talking. Think about where we were at the beginning of the pandemic. Some of you probably remember this headline at the beginning. It was sort of shocking that Dr. Tony Fauci would make the statement that as many as 100 to 200,000 people would die from the coronavirus. Think about where we are now, and we don't really even bat an eye at this number, that over 1.2 million Americans have now died due to COVID-19. And if you take a look at the data, even though we're certainly not where we were at the height of the pandemic, but as many as 900 people 900 people still die due to COVID-19 reported to CDC each week. And this is about 2 to 3 times more than it was where we were in the spring. So this is a remarkable kind of statistic that I encourage you to continue to track and think about in the context of what it means to put the COVID-19 pandemic behind us and kind of normalize some of the disease. Because who are those people who are dying? Probably the people who have experienced healthcare disparities all along. And again, another way to kind of think about this, this is a severe year for respiratory illnesses pre-pandemic. This is when we were messaging, sounding alarms, pointing at red flags. Over here in the orange is where we were this past season. This is what we now call a moderate season. And the reality is that the predictions for what's going to be coming up this season are also not promising. It's probably around the same place where we were at the last season. So we have a lot of work to do to be able to remind people that in fact we shouldn't be normalizing this level of disease. We didn't tolerate before the pandemic. So why are we tolerating it now? Again, because those people who are going to be harmed and disproportionate impact are those people who have been disproportionately impacted throughout the course of the pandemic. And not to mention, in addition to hospitalization and death, which was highlighted earlier, we're just beginning to learn more about long COVID. We're trying to figure out how to measure this, just to highlight this as an issue that is ongoing. And so long as variants continue to emerge, and they are, and COVID-19 now circulates along with other respiratory viruses, it's changing the way that we think about respiratory illnesses. It's not just a fall and winter season issue. This is probably a year-round issue. And as many as, again, at least 50% of new infections are due to asymptomatic spread. So all kind of important things that go into our core recommendations. This is why public health and all of us in healthcare should be continuing to illustrate the importance of layered approaches. That is, staying up to date with recommended vaccinations, wearing a well-fitting, high-quality mask in indoor public spaces, and taking steps to improve ventilation, staying at home when you're ill, and actually testing early and getting treatment early if you're eligible. And I think Washington State, specifically this region, I think has had a unique role and played an important role at the beginning of the pandemic and provided information for the rest of the nation, the rest of the world that we continue to use in our guidance today. And we have a very important role kind of going forward to not necessarily normalize disease, but really we should be normalizing these pandemic lessons learned into our routine activities, because it's through these layered approaches that we're going to be able to kind of achieve that. And we've got a long ways to go, but I hope that all of you can be public health advocates. So thank you very much.
Thank you so much. Yeah, we have time for a few questions. So either in the chat or in the room.
Sure. Thank you so much, Eric, for that. I'm sure you've heard the data from school systems about attendance and the change in culture following the pandemic. And I'm raising this really related to your statement about staying home if you're ill. I think we struggle in family medicine with what does that mean? What is ill? And especially as we begin to see some that I think you mentioned something presentism, was that the word?
Presenteeism.
Presenteeism. Um, how do we navigate? How do we help parents, for example, recommend? I'm just aware of all the parents that struggle to bring their children to daycare, understanding that maybe the whole daycare was in a pre-symptomatic state.
Sure.
And
yeah.
I just know it caused a lot of upheaval. And so any guidance you can give us would be great.
Yeah, it's a difficult topic because and a difficult area to kind of help people navigate. But this is why we highlight the importance of layered approaches, right? It's yes, there's some places where it's not going to be practical for every little symptom for people to be staying at home. And I think the daycare is probably one of those examples, not to mention, again, the possibility of asymptomatic spread. But for those situations where masking is a possibility, improving ventilation is one of those things that we're really trying to advocate for. And also not to mention, like, again, a lot of the responsibility is actually on the adults. If you're coming to work ill, that's problematic. There should be better policies to allow people to, easily stay at home and not be spreading it. But yes, the school piece, I think there's a lot of components there. That's why I think the layered approaches, we need to think about that. And what are the things that we can change, which is, again, taking steps to improve ventilation and making sure that, those children who are able to wear a mask do so and able to do so safely.
Thank you for this great presentation. Really helpful and updating. Sorry, so people can hear me, right? I understand you're a public health professional, so this might, I don't know to what extent you're aware of some of the ideas around why, treatment of risk factors for severe illness is so effective at reducing mortality, particularly the semaglutide results that came out recently. I'm just curious if there are any steps, and just to state what that was, a couple of weeks ago there was a release of data from a large trial of semaglutide, which was being done coincidentally at the same time as COVID coming out, and people got sick at the same rates but had almost 40% less mortality. And these were, even if they didn't have less weight. So it was something about taking semaglutide that was really impressive. And it just is really interesting. I was just wondering the conversations that you might be involved with.
Oh, sure. Yeah. I mean, I think this is a really good example of, all the things that we continue to learn about COVID-19, and what COVID-19 is not just teaching us about viruses, but our own bodies and how inflammation and severe disease occurs, not just for COVID-19, but other pathogens as well. I don't know if I know enough to be able to answer that specific question, but I think there's a lot of studies going on about metformin's use, particularly around long COVID. There are a lot of mechanisms of action that I don't think we fully understand, just observations that we made when people were taking these, and the risk reduction and subsequent and outcomes in some of these patients that were using it, and then turn into clinical trials. I think now we're working back to try to understand that kind of pathophysiologic mechanism. So unfortunately, I don't necessarily have a great answer for you.
There's a question in the chat that asked, are vaccinated people less likely to spread COVID if they have asymptomatic COVID?
Gosh, that's a great question. I don't know if anyone truly knows that. I think the hope is that obviously if more people get vaccinated, that the risk of transmission decreases. But I think what is very clear from the data and our experiences nowadays that vaccination alone, even staying up to date with recommended vaccinations, doesn't reduce your risk of getting the infection. Anyways, just to say that this is why, again, layered approaches is really critical, that even though you're up to date with recommended vaccinations, these other steps are really important. Think about that Swiss cheese model again.
In terms of the risk reduction for long COVID and using that as a selling point for vaccines, how up to date, everything changes, right? So how
Sure.
up to date is that information? We've got people who've had multiple infections. They've had 5 and 6 vaccines. Can I still tell them that we have data that shows us that will reduce the risk of long COVID?
Yeah, so that specific statistic that I showed you from the Norway study, I think that was maybe about a year ago. But there are other studies, including the through the Recover study, that also further shows the risk reduction in more like more recent phases of the COVID-19 pandemic. So yes, there is still a role for vaccines in long COVID. But it is, again, it's hard to measure. That means you have to be measuring the effects every year and in the moment and trying to come up with a vaccine, calculate the vaccine effectiveness.
Just to be clear, I think the question is, if someone got immunization, except for the most recent one, or it had been up to date with the immunization, but was exposed to a new strain, their risk of long COVID is elevated over having had an immunization for that new strain.
I think that the science suggests, and from the studies that we've done so far with regards to risk reduction in long COVID and vaccines, that staying up to date with recommended vaccinations is going to be our best way to risk reduce, the effects of long COVID. Again, also going back to the principles that if you never got the infection in the first place, you wouldn't develop long COVID. Again, going back to the layered strategy approach, that we really should be stopping infection from happening in the first place.
Okay, I know we're at time, so thank you so much. If you have a few minutes, you can stick around for
Sure.
questions. But and then we welcome feedback, and next Grand Rounds will be in a month. So thank you all for attending.